Hello, and welcome to the Radiology Economics and Policy Learning Electronic Toolkit, Replete. This program was made possible through a GE Healthcare RSNA Education Scholar Grant from the RSNA Research and Education Foundation. I'm Rich Duzak from Emory University, and this module is another part of the series on physician payment systems entitled MACRA, Part 1. This module is targeted to Level 4 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you are in a program other than diagnostic radiology, please reference the Replete resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows. To understand the historical context leading to the passage of the Medicare Access and Children's Health Insurance Program Reauthorization Act, MACRA, of 2015. To describe the two options for MACRA participation and the pathway by which most radiologists will likely qualify. And to pursue avenues to succeed both financially and reputationally as CMS further refines its value-based payment models. Here are some additional resources listed alphabetically by author for those who would like to learn more about the topics in this module. MACRA is the single most important piece of legislation impacting Medicare physician payments since the Medicare program was created some 50 years ago. It stands for the Medicare Access and Children's Health Insurance Plan, that's CHIP, Reauthorization Act. And the reason I start off the Replete curriculum for Level 4 of the ACGME ABR Economics Milestones Program, the one on physician performance management and incentives, is because this is how society is challenging our practices and our physicians to perform. So to meaningfully demonstrate the behavior we want at the broader practice levels, we need to have all of our physicians rowing in this newly incentivized direction. My key message over the next several modules will be this. Our physician-level incentives need to match our practice-level incentives, lest we fail to meet society's expectations of us. We've talked about some history before, but I think it's worth briefly revisiting the past to understand why MACRA came about the way it did. I'm not sure anybody would have designed this legislation in a vacuum, but in the context of the historical evolution of Medicare physician payment systems, the specifics of MACRA, I think, make a good more sense. We talked previously about the good old days of physician reimbursement, where folks paid cash and sometimes bartered for physician services. Those were simpler times, but with regard to all patients getting access to health care, things weren't necessarily so good. In the 1960s, President Lyndon Johnson ushered in the era of the Great Society. Legislation at that time created the Social Security program, helping to ensure retirement funds for Americans who had reached the age of retirement. Legislation also introduced the Medicare program, which created a health insurance system for those individuals who had worked their entire lives, but now, at age 65 or thereabouts, no longer had employer-based insurance or the income to buy commercial insurance on their own. As you recall, Medicare originally paid physicians based on usual, customary, and reasonable, UCR, prices, and these varied wildly from community to community and from specialty to specialty. As a national program, uniformity was necessary, and so the government engaged Dr. Bill Shao from Harvard University to develop the resource-based relative value scale. As we have previously discussed, the RBRVS establishes relative value units. Those are RVUs for the work, practice expense, and malpractice expense associated with virtually every billable physician service. The system then adjusted each of these regionally for the local costs of living and doing business using so-called GPCIs, Geographic Practice Cost Indices. Those adjusted RVUs were then summed and then multiplied by a conversion factor determined by Congress each year. That resulted in a dollar amount for each service under the Medicare physician fee schedule. That conversion factor, however, was based on flawed, sustainable growth rate methodology, which proved in many ways problematic over time. The SGR, the sustainable growth rate, was calculated each year in the very complex manner you see here on the right, using a formula that no one really understands. But the very premise behind the SGR calculation was inherently flawed. Medicare assumed a behavioral offset, meaning that when Medicare spending grew faster than inflation, that the program would cut payments to keep things steady, and that somehow would be a message to physicians to curtail utilization. But the reality is exactly the opposite. When reimbursement went down, physicians generally increased utilization to maintain their incomes. It's all part of the supply-driven utilization process that we talked about in recent fee-for-service modules. And so what happened was this. You can see here the initial conversion factor of about $31 in 1992 when RBRVS was implemented, and how the conversion factor remained relatively steady over time. But when you look at the changing cost of living over that time, the conversion factor didn't even come close to keeping up. That $31 back in 1992 should have translated to $53.26 in 2016, but it increased to just a bit above $35. And so for years, doctors screamed that the system wasn't fair, which led to ongoing annual congressional lobbying to temporarily patch the conversion factor and ultimately fix the sustainable growth rate. That's one of the things that happened as part of MACRA, or so, as I'll tell you about in a moment, folks would say. One of the big problems with RBRVS then was the conversion factor methodology that I've now highlighted in red. But the other one is far more fundamental. It is how Dr. Shao defined value. Remember, we talked about his definition of value being one of provider resource utilization. It was defined through the eyes of cost accountants and physician practices, but not patients. And so it led to a number of unintended consequences that we've talked about several times. When we talk today of value, we really mean something very different. We mean bang for the buck, or quality relative to the cost. And that's what former Secretary of Health and Human Services Sylvia Burwell meant when she outlined in 2015 in the New England Journal of Medicine her bold proclamation of moving Medicare payments from being volume-based to being value-based. It's entirely aligned with MACRA. And so what MACRA represents is a bipartisan action by Congress to formally direct Medicare to continue to move our health system from one that increasingly incentivizes higher quality and lower cost care. We talked in the Pay for Performance modules about recent Medicare value-based physician programs of recent years. You see them listed here. To understand MACRA, we need to review those briefly. We spent a good bit of time talking about the Physician Quality Reporting System, PQRS. Remember, PQRS paid physicians based on whether they checked boxes or didn't with regard to documenting specific quality measures in their reports. You see the initial list of metrics here. We spent less time talking about the value-based payment modifier program because most radiologists were exempt, as were anesthesiologists and pathologists, the so-called RAPS specialists. That's because it's really hard, and maybe even impossible, to attribute costs to these specialists, since other physicians are largely controlling their patients' care. So for radiologists, as long as they participated in PQRS, they got a pass on the value-based payment modifier program. It's worth highlighting, though, that the value-based payment modifier program established bonuses or penalties based on a physician's quality of care relative to the cost of the care. Look at the words I've highlighted in red. Quality divided by cost. That's value, remember? And so Medicare has been pushing this agenda for a while, but previously with only very few dollars at stake, until now. Under MACRA, this becomes much, much more relevant. And you'll remember that the third program that CMS implemented to improve value, or so ostensibly so, was meaningful use, or as I like to refer to it sometimes, meaningless abuse. You see the stages here. It's the program that requires us, even as radiologists, to record smoking status for our patients when we do H&Ps, and to open our patient portals up for radiology reports. With regard to dollars, though, like other hospital-based physicians, radiologists have largely been exempt. But for our clinical colleagues, where the dollars have really been at stake, this has been an immense headache. Back to MACRA. MACRA legislates new payment models to promote value. Remember what we talked about what that means in a recent module. old payment models is basically synonymous with fee-for-service. New payment models can be either pay-for-performance or accountable episodes. They're also called alternative payment models. And under MACRA, these APMs become further codified. Pay-for-performance is now formalized as the MIPS program, the Merit-Based Incentive Payment System. And accountable episodes are now formalized as AAPMs, Advanced Alternative Payment Models. MIPS and AAPMs are now the two ways that you'll be able to participate in MACRA's Quality Payment Program. MACRA both giveth and taketh away. We'll talk about the details of MACRA more in the next module. But under the program, the sustainable growth rate will go away, as will, at least in name, the PQRS, the Value-Based Payment Modifier System, and the Meaningful Use Program. What it will create will be MIPS, the program by which most radiologists will participate, as well as Advanced Alternative Payment Models, a program by which, at least to start, only a very, very small minority of physicians will be able to participate, and only very few of those will be radiologists. We'll talk about both of these in far greater detail in the next module. In summary, MACRA represents the biggest change to Medicare's physician payment system since the Medicare program was initially created. MACRA legislatively incentivizes providers in a manner intended to promote higher quality and lower costs. Huge dollars will now be available for physicians who embrace these new imperatives. But physicians who continue to cling to traditional volume-based metrics will increasingly find themselves disadvantaged, both financially and reputationally, as you'll learn about in the next module. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the Replete initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in Replete.